Kia ora koutou, welcome back. I hope you're all refreshed from cups of tea and coffee and things. We're just on time, we're 1 minute over time. So let's start off with Michaela King. She's going to give us a little update on some migraine medications in New Zealand. Thank you.
Hi everyone, and thank you very much for having me. We're very pleased to be able to sponsor the event today and just want to acknowledge the Migraine Foundation and the Neurological Foundation for bringing this event together. I'm just presenting a very short update today just on a couple of treatments that we as AbbVie supply here in New Zealand. Just to disclose, I am an employee of AbbVie. Please, we do encourage you to speak to your healthcare professional to understand if either of these treatments are right for you. I myself am not a doctor, so please don't come and ask me if it's for advice. I am not the best placed person to speak to you about this. I am an economist, and my role actually in AbbVie is, so I lead our work engaging with Pharmac in order to try and get these medicines funded. So that's my role, but also I've been working on Equipta as well, so that's why I'm here today. If you do have any need to report an adverse event or product complaint, or would like more information on the medical side, there is some contact details on here if you want to take a note of those contact information. Firstly up is about Equipta or atogepant. So it is MedSafe approved here in New Zealand for use in prevention of migraine in patients who have at least 4 migraine days a month. It is an oral tablet taken once daily. It is not funded at this stage, but it is available as of now for private purchase. This does mean you will need to pay for it, and obviously as normal doctor charges apply as well, and I will tell you a little bit more about that process. We have submitted a funding application to Pharmac, and unfortunately the way Pharmac operates, there's no definitive timelines on if or when they will fund it, but we are actively engaging with Pharmac, and obviously that is our end goal, to try and get this medicine reimbursed so it is available to everyone who needs it. So we have set up an access program for atogepant in the meantime. We know this is not ideal, it does mean you need to pay for it. The access program is set up with a discounted price. In order to access this, you need to have your prescription sent to Airport Oaks Pharmacy, which is based in Auckland. However, they can courier the medicine anywhere in New Zealand, so everyone should be able to access it through this program if you choose to do so. The cost of it is $352.82, inclusive of GST or markup, so that is the price that you will pay at the pharmacy, and that is for 28 days supply. If you do need it couriered, there is a small $6 to $12 charge, depending if you live in an urban or rural location on top of that. It is available as well from any other pharmacy, however, they do not have access to this discounted price. If you do wish to get it from any other pharmacy, we would encourage you to reach out to a few different pharmacies, as markups can vary, so just to understand the different prices that are out there if you wish to go through this channel. Also, just want to touch on Botox. This is not a new medicine, but we thought just worth highlighting its availability in New Zealand. It is used to treat headaches or prevent headaches in adults with chronic migraine, so a slightly more restrictive indication there. The good news is it's funded, but unfortunately this is restricted to the hospital setting. So it means you need to be referred and accepted into a hospital in order to access funded Botox. I think the main barrier that we understand at the moment is not all hospitals are providing a service in which you can access Botox, but that is rather at the hospital level, so it's not a Pharmac issue in this case. So really, if you are having issues in accessing it in the hospital, it may be because that service is not offered, or in terms of getting a referral and acceptance into that hospital as well may be the barrier. Outside of that, obviously, it is available for private purchase as well, and obviously there is, which means you will need to pay for it, and obviously the cost of the doctor's charges on top of that as well. I will just leave this information here. This is the minimum consumer information that is available. I also have printed copies of the full set of consumer information is on the desk outside if you wish to pick up a copy of that. For Equipta, we also have a booklet outside which includes a lot more detail on the medicine and also the access program. So if you wish for more information, you can pick up one of those. There also is a website that we have developed as well, which is equipta.co.nz. The booklet is also downloadable from that website. And we would encourage you to speak to your doctor. The website is just for additional information, but it's not intended to replace that conversation with your healthcare professional. But it is there if you wish to be able to look up some more information on it. Information has also been shared with healthcare professionals around the country, so hopefully they have access to information as well. And that's all from me. Thank you.
Thank you, Michaela, and we do want to thank and acknowledge AbbVie for co-funding this event, and we do want to thank AbbVie for actually being in New Zealand and providing some of these resources for us. So I'd like to welcome Dr. Kelvin Chan for our next session.
Tēnā koutou, tēnā toto, kena toto katoa. Thank you, Fiona, for the very kind introduction, and thank you to the Migraine Foundation, Aotearoa New Zealand, and the Neurological Foundation, as well as AbbVie, for making this particular event possible. It is for you, the patients, and we're here for you as well as physicians, although we wish there were more of us to be out there for you. Unlike the previous speakers, I am actually talking in front of my teacher. So it is a little bit more nerve-wracking for me, especially after the excellent talks that's been provided before. I've got the slightly more difficult position in terms of going, what is available and what isn't available in New Zealand? How do we get to a stage of accessing things? And with what is available, what do we know about it? And should we go ahead with something like this? Oh, I'm meeting my speaker. Hi. So I'm part of Palmerston North Hospital and affiliated with Otago and King's. These are my disclosures, of which some of the medications and therapeutics that we discuss are provided by some of these companies, apart from MedLink, which provides education. And when we talk about management, unfortunately, it sometimes starts off with you as the patient. And you would have heard a number of different things in terms of lifestyle management, and your GP would put kind of the onus a little bit on you. And I don't want you to think that that is where it's going to end. And a lot of you would know that that's not where it ends, because if that's where it ends, we wouldn't be having this particular talk, and we wouldn't have had all the research involved in it. But we do know that we can modulate a few things. We might not necessarily solve it all, but we might be able to modulate a few things through lifestyle management. For a few people, lifestyle management is all that is required in terms of getting adequate control, but it might not be the case for your particular situation. There have been some studies that are upon sleep. There have been research upon the biology of sleep and the neuropeptides that are involved in sleep and how that has an effect in migraine. We've seen studies on diet, and they're a little bit fraught because they all seem to be effective. We've seen studies on exercise as well, and you'll be asking yourself, how hard, how much, how long, what should I be doing? There's things on psychology, cognitive behavioral biofeedback work, as well as what about supplements? What else can I take that's not a pharmaceutical? I really do want to plug in the Australian New Zealand Headache Society. There is a website up there. There is information on there. I've I put this one out to every patient of mine to look at the self-care that you can look at. Now, this is only a small snippet of it. I'm not saying this is the thing to really focus upon, but they also have other really good resources as well. It is more Australian-centric, so finding physicians there is quite easy if you're in Australia, probably a little bit harder over here, and I'll go a little bit more about that a little bit later on. I think lifestyle is somewhat important, and I've just pointed to this particular paper, which is a bit hard to access if you don't have a subscription, by Nazia Kassan, which really does talk about the homeostatic processes, and Professor Goadsby has already spoken about how the hypothalamus is really a key neuro part of the brain that is involved in the processes that we experience, especially some of the premonitory type symptoms that he's already mentioned to you before. And a lot of people will say, you know, I don't sleep as well, I'm feeling tired, I've had a change in what I want, I don't feel like eating, my thinking's not quite all together. And it's a combination of different symptoms that begin in the process. So when I'm talking about lifestyle management, what I'm saying is that this is a biofeedback loop. The hypothalamus has got some control. It gets told, yep, this is a good time to eat. Yep, this is a good time to go pee. And it's a good time to go to sleep. But if you start fiddling with that and you alter it, it is a little bit hard. It's working a little bit harder and it's doing other things at the same time. So having some sort of, stability can be helpful. It's not going to solve the problem necessarily, but having some stability would be helpful. Having some predictability would be important. When I talk to people about sleep and exercise, I talk to them a little bit more of the sense that this is a thing that's good for you. Sleep is generally good. Exercise is good, and it has lots of different health benefits, and having a healthy diet is good. But it's a change. It's still a change to you, and your brain might not like that change right now. It will hate that change. So any change could lead to a worsening for a period of time before kind of a little bit settles down. So if you decide that you're going to start doing couch to 5K or couch to 10K, if you're going to decide that now is a good time because hot and spicy is back at KFC, I'm just going to hit that before it goes, they will probably both, despite the fact that from a health perspective, they're very different. Obviously, one is frowned upon and the other one's not so frowned upon. I won't say which because my wife will comment about my health choices. It will lead to a change, and it will just take a little bit of time to kind of settle down, and that's a little bit about the kind of brain processes that are happening. Up on there will be a headache diary as well, and I really cannot stress how useful it is, not just to me all the way down the end, but your GP in terms of communicating to other people, to look at whether or not something is effective. You don't have to go into high detail. It could be just, I have a headache, I've taken some treatment, I took this treatment. It just gives us a little bit of an understanding about what's going on. We could go in the more archaic age and use paper, and I tend to use paper because it means I can look at multiple months at the same time. But you can also do be more a modern human and use an app or something like that, and those work well. Apps can sometimes be a little bit more fraught. It means I have to scroll and memorize things. Hopefully I can do that. Maybe your doctor's better with a photographic memory. But they're really helpful. And it's really helpful because if you do things like this, and I've just generated this, you can see that November was better than October. And you can do it by numbers, you can do it by mild, moderate, severe. And I've put X's just to say, hey, I've taken some pain relief. And I can flick down, and maybe you did an intervention, maybe you did something at the end of October, and you go, well, was that good? Was that helpful? Did that lead to something useful? And if it didn't lead to something useful, it's either it's time to move on from this thing that you've tried, because it doesn't work, or it's time to increase, let's say if it's a pharmaceutical, it's time to probably talk to my GP about increasing it, because there's no point being or doing something over and over again, waiting for it to have this effect. When it's not, it's called insanity. Right, so let's go talk about a couple of things that you could possibly do. I'm going to focus first on the things that are not stuff that we do to you. So there's no surgeries in this. We're not going to stick something into you at the moment. I got a little bit interested into yoga because my wife became a yoga teacher in between her medical time while we had children. And I was working with Professor Goadsby at the time, and she looked at yoga as to whether or not that can be helpful. Now, a number of people will find that the right-hand image of that downward dog just horrible. Just no, why would you do that? You may think to yourself. So there are some trials that are out there, some randomized controlled trials. The difficulty with studying yoga, as you probably have worked out, there's different types of yoga. There's yoga where you are what they call vinyasa or power yoga, and then there's the other ones which are a lot more relaxed, like yin yoga. So they're very different in terms of the physicality required for each one of them. And so the styles are different, your sequence is different. Unless you're doing Bikram where you're just going to be sweating the whole time and suffering, it's got to be different every single time. And because of that, it's really hard to study something that has variation without consistency. And which one is better? How do you define one sequence is better, one technique is better? But in general, there's an impression that this is not a bad thing. Can be quite helpful. And the most important thing is that there's actually no harm in doing it. You don't really hear people having serious outcomes unless they're going for a really long stretch and pop something they shouldn't have popped. But most of the time, this is no adverse effect. So it could be a useful thing to add on and be part. And again, exercise is a healthy thing, so not necessarily a bad idea. What about acupuncture? Again, very difficult to standardize the studies that are there. There are a number of studies out there, and it's very difficult because everyone does something slightly different. Because they're trying to work on what you're telling them. And one of the hard things is that what you're telling them may sound very vague and very different one day compared to another day, because we just don't have that kind of level of localization, as Professor Goadsby has said, with the drawer in terms of this is the part, and so they go for that particular region. And they will go for that particular region, which will be different to another person, will have a feeling in another way. So they kind of adapt. It's a little bit hard to get that kind of standardization. But once again, the good news is that this is not harmful as well. And for a number of people, this can be quite helpful. There's some impression that it gives some short-term relief, although these trials aren't strong on that and doesn't have the evidence for it. And again, this could be something that you can add on if it works for you. If it speaks to you, that's the thing you're probably going to hear from me a little bit, especially with the non-pharmaceutical treatments. If it speaks to you, and if it works for you, and it's not harming you, and bearing in mind some of these things cost money, but YouTube is free apart from your internet connection, then this is not a bad thing. It works for you. I'm happy to have that as part of your management. And anyone who says that they aren't probably it's not quite getting what needs to be done next. Now, this one I do have a little bit of caveat upon. There are a number of chiropractors out there who have practices, and there is practice out there specifically for headache management. The study quality, again, is a little bit fraught, and there's different things in terms of when you look up chiropractic care. There's spinal manipulation, and then there's cervical manipulation, which is your spine above from the neck upwards from the neck. And the difficulty is that, again, quality of the studies is just a little bit fraught to go, yep, that's a great idea. There's a thing called a meta-analysis where people kind of take in lots of data from different papers and different studies and try and see if they can match it up together and see how good the information that we have, and kind of collect them all to see if we can get a more concrete conclusion. And there's some impression that maybe this can be helpful. I personally have just one little issue with it, only because of my time at Hamilton Hospital, where I did meet an unfortunate young man, and this is not his scan on the right-hand side, who did suffer from a vertebral artery dissection. Obviously, the chiropractors wouldn't want you to be aware of it. I want you to be aware of it only in the sense that I don't like the idea of rapid manipulation of your neck by somebody else. You don't have the protective control of it. The neck, the cervical region has quite a big range of motion. You can go for almost a good 180 in most people, but areas like your thoracic or your abdomen, your chest, sorry, or your abdomen, your lumbar spine, they've got very limited range. So you've got a huge range, and the blood vessels actually sit around, surrounded by bone, and then there's a space, and there's more bone again. There have been case reports of people who've had vertebral artery dissections. What I'm trying to show you on the bottom right hand, which lights up, is a stroke. This is a way for us to identify a stroke on the scan. Quite rare. Am I saying don't see a chiropractor? No, I'm not saying that. Am I saying that you should avoid them? No, again, still not saying that. What I'm saying is that if it works for you, great. If they're going to manipulate your neck, okay. Gentle manipulation, not a problem. Stretching, not a problem. I'm more worried about the rapid manipulation side of things, and that's a case that hasn't left me when I was a junior doctor. Mm-hmm.
I would just like to point out that no New Zealand trained chiropractor would inappropriately manipulate the neck, but also all of the studies and cases for any of those dissection incidents have all happened overseas, and there has been no dissection injury ever occurring in New Zealand or by a New Zealand trained chiropractor.
Sure. I can't, for that particular case of a vertebral artery dissection by chiropractic care, I did not and cannot confirm because we didn't ask. That wasn't what was important. We were looking for a mechanism at that time. But I cannot confirm in any way, and I think that's fair enough, and there's a disclosure, that that person was a person that was trained with the accreditation that you've mentioned, but it was certainly done in New Zealand. And there has been, as you can see at the top there, a complaint before about an individual who had a vertebral artery dissection after chiropractic care. Again, I'm not specifically stating that any one chiropractor is or is not. I certainly do see patients who have had chiropractic care with rapid manipulation of their neck. And again, I cannot state to you because I did not ask, because it wasn't relevant to me whether they were or not. The important thing from my perspective was, are we being safe in terms of what is being done to them? Because as a patient, as a client, the number one thing is your safety, and number two is consent. And you can consent. You can say to me, well, if I give you a recommendation, no, I don't want that. That's not for me. You're going the wrong direction. And if I can't adapt to it, you shouldn't be seeing me. And I shouldn't be seeing you really as well, because we can't develop a therapeutic relationship. And what I'm saying is that as a patient, you should be feeling empowered that, yep, I think this might be useful for me. I want to give this a go. And you should feel the ability to do so. But you should also be able to say, hey, I'm not quite sure this thing is entirely safe. I have heard some things about it. Can we not do that, please? And I think in developing that therapeutic relationship, which I believe would be part of your code, is really important. But thank you for the comment. This is a little bit more gentle, down towards massage. If you can convince a partner to massage you, this is a good one to go for it. Because again, also safe. there are small studies that have shown some benefit. Again, same fraught problem of not being well powered. And again, like I said to you before, these are useful things to help with your experience of it. These are not pharmacological. These are things that you can access, and unfortunately, because of the difficulty of accessing medical care, which I will speak a little bit about in a moment, you kind of want to know, is this hard? Should I go down that line, and that's going to be possibly my answer? The evidence suggests that probably not, but there's not to say that this can't be helpful and help in terms of your journey and your experience of this, because this is from what I've heard from people, this is a journey and it takes a while. Cognitive behavioral therapies or biofeedback or different forms of managing pain through one's experience, because it is an experience. So it wasn't until I worked for Professor Goadsby that I really understood migraine biology in a family sense. I had the occasional headache, but it didn't really bother me. But I have family members who have what would be full-blown migraines. And I wouldn't have ever said that I would have had migraine. But then when I sat down one day, being a little bit grouchy to my children at the time, I realized I wasn't really feeling that hungry at the time. And I was like, oh, there's that migraine biology in my family coming out a little bit. And now I understand what that feeling is. I understand how I should be able to manage it. Am I in a lot of pain at the moment? No, I wasn't at the time, but I can process that, and having a little bit of an understanding does actually can be quite helpful for some individuals, especially when it's combined, and certainly in the studies, with pharmaceuticals. They can actually improve together your headache burden in terms of how many attacks you may be experiencing, or how severe the experience is, or how you feel the experience as well. And so that can be quite useful as, again, combining as part. And all these bits, like I keep saying, take the bits that speak to you, because that's what's the important part. I'm no way stating that you should buy one of these products, or specifically those brands. But there is small studies in terms of supplements that are out there. I know a couple of my colleagues do like talking about the last one, which is Migradol. But if we can get the last one to work, there we go. There are small studies that show that these particular supplements can be helpful. They're not very strong studies, or one or two for each one of them at most. With coenzyme Q10, generally pretty well tolerated. You might get some jaw discomfort or bruxism that's out there. Magnesium diarrhea is a common one. For anyone who drinks Berocca, you'll know what Berocca P is, where you get that fluorescent yellow urine. You'll get the same thing with riboflavin as well. But these are generally pretty well tolerated, and they're also on that self-care for migraine sheet that we have in there. These doses are evidence-based doses, as in they've gone through clinical trials. There was one study that threw all three of them together, and that seemed to be positive, but there's no comparison study. There's no study to say that combination is better than one alone. So again, nothing wrong with taking the combination of riboflavin and magnesium together, but there's no study to say that's better than just magnesium alone or riboflavin alone from my readings. But I do know a number of my colleagues do find that it's probably the easier way of getting riboflavin, which is only really available that I can find from Chemist Warehouse or Bargain Chemist. I haven't found it in any one of the other health food shops. I do need to put in this warning, although I believe other people have given this warning already. So if you need to avert your eyes, this is the time now. And Professor Goadsby has already brought forward chocolate, because that is probably the most common avoidable trigger, if you will, that I keep hearing from people. And I'm glad that I can say this to a lot of people, but I I don't think this is from the evidence, this doesn't seem to be a trigger. There have been provocation studies where they took people who said chocolate is a trigger, it consistently is a trigger. And so they fed them chocolate, which is such a horrible thing to do to them. I have no idea what kind of chocolate was. But they gave them chocolate and they did diary studies on them and they were inconsistently triggered. But then they did some really horrible things. I believe one of them was done in London, where they gave people chocolate or carob. And they did another one where they gave people chocolate and this kind of compound, which was sweetened with artificial flavoring and was fat. They really stressed the amount of fat that was in it and the texture of this thing to be as close to chocolate as possible. And they were unable to demonstrate that chocolate triggered attacks more so than something else that was chocolate-like. Apparently they made it so it was that good that you couldn't tell the difference. And as has been mentioned by Professor Goadsby, likely this thing is not really a trigger, but are you sugar craving already at that point in time? Going a little bit sideways from that, I have a colleague of mine who swore to me, absolutely swears to me, that cheap beer causes him to have his attacks. Not craft beer, cheap beer. And as long as he continues to drink craft beer, he's perfectly fine. He's a bit older now. He said this was just happening when he was in his university age kind of days. Back in med school. I suspect that one of two things has happened to him. He's gotten older and he's male. And other thing is that he's become a snob. Right, so we're going a little bit into the pharmaceuticals at the moment. The stuff that I'm really talking about, you kind of do need a prescription. So you should go, this is the point of time that you're going to have to see someone in the medical field, a GP or a pharmacist to attain these. There are triptans, and it's I haven't got the slide up there, but I'm sure a number of the audience has seen the data that Dr. Imlich has produced in terms of who has had a triptan. We don't have many triptans. We have 2 triptans, and I'll show you them in a moment. They're available. There are oral and one injectable one. But then we kind of forget the other thing, because the triptans are mostly focused upon dealing with head pain. And in general, you can probably manage the other stuff as well because it gets better when the pain gets better. But we still got the postdromal symptoms that might be still going on. And while we talk about premonitory postdromal symptoms as if they're kind of separate to this headache symptom, they actually all kind of overlap over time. And so you might still have nausea going on despite the headache is being done. So there are antiemetics or anti-sickness tablets to help with nausea. There's a bit of evidence to suggest that metoclopramide combined with things like paracetamol or ibuprofen and aspirin can be almost as good as a low-dose sumatriptan. So again, if you're nauseated as another symptom, I can't do much about light sensitivity, you can get an anti-sickness medication from your GP, and you should take the opportunity to ask, because not every GP remembers to do that, because they're like, oh, you've got head pain, let's deal with head pain. This slide could be a lot sadder. I've put up there mostly what we've got available. Red is bad, green is generally good. We have sumatriptan and rizatriptan orally and the subcutaneous version of sumatriptan available, and they're all funded. But some of the, there are actually about, if I remember correctly, 7 triptans, internationally, probably 9 triptans available. We've only got 2 here. And the thing about the triptans is that just because one doesn't work doesn't mean another won't work. We're all different, and these are all slightly different in themselves. And some people respond to one over another. I have put down the G pants that are available, and as well as the what's known as the Ditan. We used to call Ditans, I believe. I think I've seen lots of presentations with Ditans. We've only got one available, and none of them are available in New Zealand. Rimegepant or Nurtec is available in Australia, and even under the PBS or the Pharmaceuticals Benefit Scheme over there. I think that if you have lots of attacks that debilitate you, and lots could just mean one a week. If it puts you out and it's pretty bad and you are just done for the day before the day's even started, you probably, and our acute treatments don't work to get you out of there, you probably do need a preventative. And if you've got, I know there's this kind of funny line of 8 headache days, which your GP might say to you. If you've got debilitating headaches, we should be thinking about a preventive. We can't just be acutely treating it when it's there. And I've listed a number of preventatives out there. The one in red is not Pharmac or MedSafe approved, and most GPs and even neurologists will be a bit uncomfortable about using. The ones in yellow are the ones you kind of have to pay for, and I've mentioned a few of those already, or you may need to see a physician to do. Professor Goadsby mentioned about neuromodulation, and I thought I'd just take this time to just talk a little bit about them. He mentioned about this one that you put on your arm, known as the remote electrical neurostimulation, and there have been other ones that are available. The ones on the left-hand side are actually available to purchase. The Kefli is a funny one. You can get it into the country. It isn't WAND approved. WAND's a special kind of, it's the equivalent, it's MedSafe for devices, not pharmaceuticals. But yet we can still get into the country. And it is a neurostimulator and has got evidence for acute and preventative treatment as well. The one down below it is called the Gamma Core, which is an external vagal nerve stimulator. The evidence for that is probably better in cluster headache, but it is available. It's just very costly, and there are the physicians who I'll mention at the end of the talk would probably be the ones that would have the most experience with it and would know the most about whether that's a option moving forward. Unfortunately, none of the options for neuromodulation are funded, and none of them generally are covered by insurance companies unless you've got like the highest level of insurance cover that I'm aware of. The one on the bottom right is the TMS device, which is a transcranial magnetic stimulator, which is almost impossible, as far as I can tell these days, impossible to attain now. But it's another example of me showing you that there are different ways that we can modulate the system in terms of which are not pharmacological, that can not only manage the attack at the time, but also prevent attacks in the future. And it's just to say, it's not just all drugs. And I put this in there because unlike recently with the G-PANTs, all our treatments have been one or another. It's acute treatment or preventative treatment. And neuromodulation kind of seemed to be able to do both, which was great, but different, but a little bit fraught because of access. I do want to make a little mention about this bit. When we talk about treatments, there's always a little bit of caveat about evidence, and then similars or things that are similar. The ones on the right-hand side are a lot cheaper. It's a little bit harder to get the top one, but you can just go down to Farmers for the bottom one, or Rebel Sport that I saw the other day, and it costs probably a quarter of the price, even if the Kefli is on special. Don't ask me about how ethically you can put something on special, but they aren't exactly the same. Obviously, the Kefli can charge a lot more because they've done a clinical trial, and clinical trials are expensive. And the others haven't quite done that, and they can't be exactly the same because you've got to pay somebody for the right to to reproduce their product. Now, I'm not saying don't do it, because I appreciate that the Carefully being about $600 odd is expensive, and this one's like a quarter the price. I would say that if you go ahead with it and it doesn't work with you, don't go, that's it. That's it for neuromodulation for me. There is no more hope in that direction. It should be, that doesn't work for me. Okay, there's some suggestion of evidence that that's probably a real thing. But if that becomes available again, and that's the work that has really been pushed by Migraine Foundation Aotearoa New Zealand, is that getting things funded and accessible. If it becomes accessible, it's probably worth another shot. This is just a slide to let you know about whether or not you can purchase certain things and how accessible it is to you, and whether or not it's funded. We've already had a brief mention about onabotulinum toxin type A by preempt protocol, or Botox for migraine. I've just put the number of injections out there. For some people, this is not for you. The number of injections just sounds terrifying, and I appreciate that. It is 31 injections, and I just mention it out there so you know. And I've put in the images so you know whereabouts as well. Because if it just doesn't sound right to you and you just don't like the idea of it, don't. And that's okay, because we should be thinking about other options as your physician. For others, this sounds great. You might get some side effects that you do want, but it's generally pretty well tolerated, apart from obviously injections themselves. But unfortunately, it is only hospital funded at the moment. And I can tell you it is very, very hard to have Botox funded, let alone be seen in hospital for headaches. Very hard to get this funded in hospital, just because it's not just, here's a drug, it's someone's got to inject you, but that person needs to know what they're doing as well, which means and you've got to go into a room as well to get it done, because you don't want every man and his dog watching you get the injections done. We've had a lot of talk about the monoclonal antibodies, of which there are 4 and only really 2 available in New Zealand. 3 are actually MedSafe approved. I'm just going to focus on those, the 2 that are available. I do apologise if the pricing is not current, but this, I would tend to talk about one over another, just because of the cost of it. I appreciate it is a bit prohibitive, and at the moment, as you're aware, there are work to get the funding for it through Pharmac. And briefly, again, through the good work of Migraine Foundation Aotearoa New Zealand, we know about things before on the website, before they formally come up and tell us about it, and that comes in with a atogepant, which has now become available, and we've already heard about that already. Here's a quick slide so that you can see availability of certain medications. And believe you me, trying to get pharmaceutical companies to come into a relatively small market is hard, but it is active work that has been done so that we have a range of things, because we know that it's not a one-size-fits-all situation. Okay, access. So in 2015, a colleague of mine worked out what would be the demand of neurologists around the country, and it should be about 74 full-time equivalents. So that's a whole person working 9 to 5, if you will, 5 days a week, and we need 74 of them. In 2022, we only had 36. So I've just been informed yesterday that that's improved. It's not been published yet, but I believe we're about almost 60 full-time equivalents, over 70 something or other neurologists at the moment. In 2022, the number of headache or concussion interested physicians have remained unfortunately the same to today. Auckland's a little bit luckier with having more people up there, but then you have more people. That's why you've got traffic. Whoops. I'm based down in Palmerston North. So up in Auckland, there's Kerry Brickwell, Rosamond Hill, whose name is probably quite familiar to a number of you, and Dr. Ray Bowes, who I had the pleasure of working with. In Wellington, there's Heidi Pridmore, and in Nelson, although she goes up to Wellington to do her clinics occasionally, is Dr. Desiree Fernandez. So what can you do in terms of helping? I'm sorry to put this back onto you, but the headache diaries, again, stress, so important. It's really important to help us work out. It helps us track things. It helps your GP track things. And when they go, oh, I don't know what to do next, we can look at it. So what would I want to know? Well, actually, I want to know a lot. I want to know as much as I possibly can. And you've seen before and you've heard before about how there's a number of oral preventatives. When I choose an oral preventative, I'm not going to just go, take this, see me in a couple of weeks, couple of things. We don't have the ability to say, because of your experience, this is the one for you. This headache experience, this migraine experience of yours, this is the best one. It's the best one for everyone. Go with this first. We actually can't do that. We have no ability to do that. When we choose a preventative, we choose it based upon what side effects we want to avoid, what side effects we might want. What other comorbidities you have that means that that's not a good idea and that's maybe a slightly better idea. That's how we really choose it. I guess with the more modern ones, which your GPs may not be as comfortable doing, that's a little bit different in terms of side effect profile. But we don't have the ability. So this is the bare minimum. But the headache neurologists that you will see want to know as much as we possibly can about you, because I'm hoping that the translational work that Professor Goadsby is doing and other headache neurologists are doing, they're going to want to know that, because maybe we will be able to find that thing that predicts that this is more likely to work than another. But I kind of want to know how often do you have a headache, and how often they're really bad, and what type of pain relief you're taking, and how often you're taking them. Because that at least gives me a little bit of an idea of your burden as a starting point. And then what has happened with the medications? Did they affect your burden? I hope we can do more, and that the slightly bleak management availability that we have in New Zealand does improve. And I want to thank again the amazing work that's been done by the Neurological Foundation and the Migraine Foundation Aotearoa New Zealand in terms of supporting you as patients and us as clinicians.
Thank you. Can I get Calvin and Peter to come up to the couches again, please? Thank you. Now, this session was really focusing on how New Zealand compares with the rest of the world and maybe what we can do to improve things. So just kicking off really broadly, any ideas from you? How can we, as consumers and as health professionals, actually work to improve access to the best sort of treatments in New Zealand? What would you guys say about that?
I think the hardest part is describing the need. And I appreciate that there's a big need for it, but I think that politically the need is not known and not fully appreciated. And the quotes about other places does not reflect us. Everywhere is different. And there is work, I believe, that you, with the New Zealand Health Survey in terms of defining that. You'll work through advocacy and speaking up and saying, hey, we exist, we're here. And through the patient groups that you're doing, is really important and speaks to us as clinicians going, we need to do a bit more than that as well. The Neurological Association of New Zealand is working on making sure there are statements about our position in terms of management, and that's been worked on by Dr. Ray Bowes and myself on behalf of the support of the Neurological Association of New Zealand. So we are working on that, but I think it's about being made aware, and the data that you've already started doing is an excellent step, and we're hopeful that more will come forward.
Yeah.
Yeah, I'm sure that's right. And the more or less equivalent sort of group, Migraine Trust in the UK, have spent a lot of time working up the information that Dr. Chan's talking about and making sure the politicians know it. Because you need politicians, as sad as that might be to say, you need to get them informed and keep reminding them of things and make sure at election time that you get some share of voice. I think it's political, unfortunately.
So there's a challenge for our audience, I think, getting politically involved in this sort of area. I'll bring it back to some things specifically around migraine disease. So one of the issues around therapies, say osteo or chiropractic therapy, is that often people get neck pain and then they think that is causing their migraine attacks. What can you say about, like, what is the relationship between neck pain and migraine, and how do you know it's actually migraine or if it's something structural in your neck that needs help?
Really, you should go to the chair of the classification committee at the point in time. So as a clinician, the definition of cervicogenic headache is that you should be able to treat it by treating the thing that's happening in the neck. And the thing is that, as you've already it's been described multiple times already, it's more than just a head pain. I think that moving away from it, it's just more than head pain, helps you define that this is a different kind of syndrome or disorder or disease. And the part that really reminds me is that, which the diagram that Professor Goadsby showed, is that the trigeminal cervical, cervical being neck complex, does involve innervations to the neck region, which correct me if I'm wrong, explains a little bit about why neck pain is so common in individuals with migraine disorder.
And related to that, you've mentioned the International Headache Society classification, and there's over 160 different types of headache types. How common is it for people with migraine to have more than one headache type? And what does that mean for your managing your migraine?
The more common thing is for people with other types of headache to have migraine, if you think about it that way, because from a biological perspective, the lifetime prevalence of migraine in North American and Western European females approaches about 50%. So that says that about 50% of North American and Western European women have the genes. It must be very, very common to have migrainous biology, if I could say it that way. So it's very common. Half the people we see in the clinic with good going cluster headache will also have migraine creeping around. And the most disabling secondary headaches, say post-traumatic headache as an example, will manifest like it's migraine in its behaviour. I think much of that is turning on the latent, stirring up the biology, you might say. That's the really common problem that happens. But of course, if you've got migraine, you're allowed to get unlucky and have other things happen, because headache itself is a very ubiquitous and common phenomenon. So it's very common.
And talking about stirring up the biology, when you develop chronic migraine, even arbitrary 15 days or more a month, there's a lot of often fear around that and concern about, is this going to continue, or what effects is that? Is there any issue around, will chronic migraine cause long-term or permanent effects for people?
No, no. And the other thing about the chronic migraine is that it will stop. because the population evidence is that the number of people with chronic migraine in the population has been stable in the last 30 years. And we know that the onset rate, it's an active onset rate of a couple of percent every year. And if it's the population stable and there's more people coming in, the only possibility is there's people going out. And I wish it was because they were being well treated, but I think that's very unlikely. So the natural history is that there'll be some improvement over time. And the other thing to say is that there's no long-term damage. If you look at populations of folks that have had migraine and you look at them in their 80s, French have done this very nicely, and you test their cognitive function, they're no more gaga than anyone else who's 80, so to speak. You know, stuff, I mean, getting old, that's got its problems. So, not that, I mean, you know, I don't want to be dismissive of dementing illnesses, of course, but there's no risk. There's no excess of lesions in the brain. There's no excess of stroke long term. There's no excess of cognitive dysfunction in migraine. It crucifies people in their productive years, and then it leaves them to regret it later on. That's why they need to be treated in their productive years.
In terms of the cognitive effects, often people find at least as debilitating as the pain. What are the treatments? Are there any specific ways you can manage or treat the cognitive effects?
Well, as I was mentioning earlier, the only thing that's emerged in the last year, 2 years now, has been the use of the GPANs acutely for cognitive dysfunction. I think that, however, broadly speaking, when cognitive dysfunction is part of the problem, I think you're in the group where you need prevention. One of the problems with prevention is we count headache days, but if you allow 24 hours beforehand for the premonitory phase and then 24 hours afterwards for the prodrome, for every headache day you count, you've got a couple of other days of disability. People with migraine, I think when they're having reasonably frequent migraine, I think they sometimes underestimate how bad they are. I don't mean to be depressive about that, but they kind of get used to being unwell. And when you get them on a good treatment and they really improve, there's this clarity of thought that emerges that lets you realise that things were worse than I thought they were. So once they start to get a little bit bad, they're probably worse. And that's a communication thing patients need to do. And it's also something that doctors need to know more about, these other parts of the attack.
I can attest to that from having chronic migraine and just learning to live with how my head felt and then coming on effective treatment, and I can't believe how different it is, and all people who don't have migraine go around with this normal brain that they don't appreciate.
It is extraordinary how people, I'm not a headache person, so it's interesting to me that people seem to be able to put up with quite a degree of disability and just get on with their lives when they could be much better.
Yeah. We had talked about aura in your presentation, Professor Goadsby. Can you explain why some people get aura and why some people don't, and why some people get aura but then don't get a headache?
Well, some people get aura because they have the genes, I suspect. They have the biology, the innate biology to get it. So you inherit a smorgasbord of opportunities of hair colour and eye colour and all sorts of interesting things, and you will inherit the machinery, you might say, for aura. Why it manifests sometimes and not others, not understood. You're quite right, you can get aura without headache, and that's because aura is not part of the headache process. That's what I think. People have other explanations for that, but I think that aura is part of it. It's a thing on its own. And it's not surprising to me that you can get it without headache. And indeed, in the 50s and 60s, it's quite common for eye doctors to see patients that have aura without headache, and they call it aura without headache in the classification, very uncreatively, but it's what it says on the jar, I guess.
But they're the same disease.
Yeah. Oh, yes.
And just one final question. We've talked about chronic migraine, episodic migraine, and you talked about people transitioning to and from. Can we explain that? Is there reasons people become chronic or don't? Do we understand that?
There are some associations with chronic migraine. Medication overuse is an association. incomplete response to an acute therapy is an association. Obesity is an association. So there are things that you can obviously do something about weight, and you can do better with your acute treatments. We don't really, but we don't understand that fully at all. Some people cycle in and out of it. That's why the line in the sand is no use. And, you know, by the time you've got to 15, you should be well on the preventive. I agree with what the chairman was saying. I mean, start waiting until you've got like 8. That's quite a lot. That's twice a week. I mean, how many people in the room can afford twice a week not to be able to do what they want to do?
Yeah.
I think we're really undertreated.
Which brings us back to the need for better and more effective treatments, and this is where I again leave it to the audience.
And diaries to count up
Yes.
what's going on and make sure you record all the symptoms.
Yes.
When you go see a doctor, if you undersell your problem, you'll get a poor result. You have to not oversell it, but just do the facts. Record these pre-days as well. Educate the doctors a little bit. There's other stuff going on.
Yes, because doctors don't necessarily ask you about all the disability that you're experiencing, and so we do need to be proactive about that. I'm afraid we've run out of time, and I thank you so much for all your questions. We've got lots of questions. We only got through a few of them, but this means that we will have more events.
Excellent.
And we are going to thank Calvin, and you also get some chocolates for... So I'll just hand over to Sarah to wrap up, and then...
Well, what a morning. I learnt so much. I think I know a bit about migraine every time I hear from migraine experts. There's so much to learn. So much incredible information. Knowing so much more is being discovered about migraine disease gives me real hope that in the future we'll have many more ways to treat and manage the disease. As Fiona said, we had a ton of questions that we have actually written them all down. So we'll try and, some of them are on our website. Some of them help to inform us about what information we need to put on our website and what people are asking. So please don't think that if you didn't get your question answered, they go into the abyss, because they absolutely won't. We've also been asked about slides. So this has been recorded and will be available on our website and the Neurological Foundation website, so you can get those there. So I just want to say quickly, a huge thank you again to our presenters. Professor Hay is already at the airport, but thank you to Professor Hay and Professor Goadsby's presentations and answering questions for us. Thank you to Dr. Calvin Chan for helping us understand the migraine landscape in New Zealand so much better, and also for bringing Professor Goadsby and Hay together for your conference so we could poach them for our conference. Thank you to Michaela Lyon from AbbVie for the update about atogepant and Botox in New Zealand, and to AbbVie for providing sponsorship for this event. Thank you to Amanda down the back for your support with managing our online questions today, and for Lee for photographing our event. And of course, I thank you again to Rich, Emmanuel, Kerry, and the entire Neurological Foundation team for partnering with us for this event. Before I turn the mic over to Rich to say a few words, I just have a couple more words to our migraine community. Living with migraine disease is undeniably hard. For so many of us in this room, myself included, it's taken away too many days of our lives, impacted our social lives and professional careers, and inflicting unrelenting and pointless pain. The trial and error of trying new medications, lifestyle tweaks, searching for elusive and often misleading triggers is exhausting. However, as our speakers have shown us today, there's much to be optimistic about in terms of migraine research and management. So much of migraine is to do with genetics, and I've always wondered, if our migraine genes are so awful and aren't of use to society, wouldn't have those of us with migraine have died out and not been able to pass on these so-called useless genes? Isn't human survival all about survival of the fittest? With over 753,000 of us in New Zealand and 1 billion of us worldwide living with migraine, that must mean there's a purpose to our migraine genes thriving. I think with migraine comes resilience and strength, and the persistence of our migraine genes is testament to that. Although some days you may not feel strong or resilient, Know that you're part of this huge family of people with migraine who are living valuable lives despite the disability that migraine can bring. You never know how strong you are until strong is your only option. Now over to Rich.
Thank you all for joining us today, both in the room, but also I think there were over 160 people joined us online today. So it really shows how much of an interest there is in the wonderful work that's going on. The Neurological Foundation is really excited to be able to collaborate with the Migraine Foundation, Aotearoa, and being able to be here today and to join you in bringing these updates. And a thank you to all of our supporters that help make these things happen. We fund over $5 million of research and education every year, and we couldn't do that without the people that support us as well. Collaborative partnerships are really important as we want to move forward. We've heard a lot about that today. Myself and Kerry sat down with Sarah and Suzanne a few weeks ago to look at ways that we could collaborate better together. Excuse me. Also, both of our organisations are part of another collaboration, the Neurological Alliance, which is 19 neuro-related charities in New Zealand that are working for advocacy and better outcomes through government and the health sector for the 1 in 3 people that at some stage are touched by a neurological condition in their life. And migraine is a significant part of that. A huge congratulations to the Migraine Foundation, Aotearoa. The things that you've done in the last 2 years have just been next level in terms of bringing awareness, education, and a focus around migraine. We work with lots of neuro-related charities, and we're just so inspired about the things that you guys have been able to do. Well done. A big thank you to Peter and to Debbie and to Calvin for sharing their thoughts, their journeys, their experiences today, and giving us some insights into the pathways of hope for the future. And lastly, a huge thank you to everybody that's made today happen. I know Sarah, Fiona, Emmanuel from our team, and a whole host of other people have worked tirelessly over the last few weeks to bring this together. So thank you all for that.